prophylaxis used to be for anyone with heart murmur, anyone with heart in 2007. And the updated version said, wait a minute, not everybody with murmur, you need to do endocarditis prophylaxis. Now, granted, we really don't have data about this. You're not gonna take 100,000 patients and study them and for something that's not gonna happen very frequent, right? So you really need to use your judgment. But they came up with this few facts. Number one, if you have any history of endocarditis, you have to be on endocarditis prophylaxis. Number two, if you have any kind of tissue valve or mechanical valve. Number three, if you have a complex and repaired congenital heart disease, you have to be on endocarditis prophylaxis. And if you have repaired ASD, VSD, if you have history of tetralogy of Fallot, which was repaired without replacement of the pulmonic valve or the aortic valve, in that case, you really don't need to do endocarditis prophylaxis. So if you have moderate, severe regurgitation, stenosis of any of your valves, you don't have to have endocarditis prophylaxis. That's number one. Number two is what kind of procedures you really need to do endocarditis prophylaxis. So the procedures that involve either major surgeries or involve a dirty tissue. In other words, if you're gonna do colonoscopy and EGD without possible biopsy, you don't need to do endocarditis prophylaxis regardless of what kind of history you have. But if you're gonna have biopsy, skin biopsy, or if you're going to have any dental procedure, or if you're going to have any kind of colonoscopy with possible polyp removal, or you're going to have the EGD with possible biopsy, if you're going to have any kind of urinary tract procedures, cystoscopy by itself is not, but if you're going to expect to have some kind of biopsy from your bladder or anything like that, in that case, you need to have endocarditis prophylaxis. And if you have any kind of GI surgeries, lung surgeries, or heart surgeries, definitely you have to have endocarditis prophylaxis. So two things you have to remember right now: that what kind of procedures, tissue valve, mechanical valve, and complex, congenital heart disease, that's not correct, is not corrected, and history of endocarditis. That's number one. Number two is what kind of procedures, dirty procedures in general, for clinical purposes, I would recommend to do it for everybody. Any kind of intervention that your patient is expected to have, I would recommend to do endocarditis prophylaxis. And the prophylaxis medication, if you don't have allergies, amoxicillin 2 grams, half an hour to 1 hour before procedure. If you have a penicillin allergy, then in that case, azithromycin or clindamycin can work. Azithromycin about 2 grams or 1 gram. 1 gram azithromycin, and clindamycin about 900 milligram. Now, if you're going to have GI procedure or urinary tract procedures, clindamycin is probably a reasonable option. So that's about endocarditis. Any questions about that? The left atrial appendage closure, came up from studies in the 90s that about 91% of clots in the case of atrial fibrillation, they form in the left atrial appendage. So, any kind of heart surgery with atrial fibrillation, it's advisable to clip the left atrial appendage. And then the left atrial appendage closure device, endovascular, came into light in 2005. and became commercially available in 2014 after the landmark trial of Protect AF that showed that these actually devices, if you compare them with Coumadin, are really safe and effective. Now, when it comes to clip the left atrial appendage during surgeries, about 30 to 40% of these appendages continue to have pouch, and the pouch can form clots. And in the case of atrial fibrillation, on these kind of patients, and the risk of stroke is high, the risk of bleeding is small, it's really it's not unreasonable to continue the blood thinner. Now, granted, if you have mechanical valve, so we don't care. So the mechanical valve has to be anticoagulated with Coumadin. But if you have patient with left atrial appendage clip and
I mean, I don't know. See, I have
appendage clip and high risk of bleeding, in that case, it's really not a bad idea to stop anticoagulation and eventually realize that there is a stroke in the left atrial appendage.
So it was trying
Remember that can you
What's the fourth question?
That's the ER.
So now the question is that this is at 3:55.
oh yeah guys, remember that if you have to individualize your care for these patients, and if they have a history of stroke and they have a clip, probably, and high chest valve score, probably just anticoagulate regardless. There's a new study actually published recently in about 1 year ago, and actually made it all the way to ACC meeting in not last November, the November before last, and they found that if you clip the left atrial appendage and anticoagulate, it's much better than anticoagulation by itself, and is much better than clipping by itself. So it seems like in these kind of patients with atrial fibrillation, if they have a clip, continuation of anticoagulation is advisable. Now, granted, like yesterday, Nick has patient hemoglobin of 8, has left atrial appendage clip. In that case, probably not bad idea, just stop anticoagulation. Document in your chart that there is actually history of left atrial appendage clip. Anticoagulation is not indicated. And always remember, when you see patients like that, you really need to figure out why is this patient on anticoagulation, and ask yourself these questions, because Eliquis or Xarelto or Pradaxa or Coumadin, not only for atrial fibrillation, they can be for other, such as DVT, PE, or other issues that, or arterial clots. So you have to be careful about that. And if they are on Coumadin, so you have to think about mechanical heart valves, and you can just listen to your patient to see if there's any actually mechanical click, to rule that out if you're, let's say, in nursing home facility. Or you can look at the sternum if there's any scar as well. Now, if you have patient with left atrial appendage closure device such as amulet or Watchman, in that case, continuation of anticoagulation is really not needed. Why? Because actually you close the whole left atrial appendage without residual pouch. And that seems to be actually pretty effective in these kind of patients. Now, since we're talking about these closure devices, remember, if you have patient with left atrial appendage closure device, or you have patient with VSD septal device closure device, or atrial septal closure device implant, you have to make sure that these patients are on endocarditis prophylaxis before any procedure for the first 6 months. Why? Because it usually takes about 6 months for endothelialization to happen on the surface of these devices, and until then, they actually can become a nidus for possible bacteria, attaching to them, and it's going to be very difficult actually to cure. In that case, you have to remove the device in case of infection. So we're very careful about that. So when it comes to indications for left atrial appendage clip, any patient with valve surgery, especially mitral valve surgery, I would recommend to clip the left atrial appendage. Certainly any patient with any kind of open heart surgery, CABG or valves, they have to have a clip of the left atrial appendage. It's easy, it would take about 5 minutes to do. So you're not going to be on the pump for a long time, and it's priceless at times. Now, if your patient going to have mechanical valve, so regardless, your patient is going to be on anticoagulation, so clipping the appendage probably is not going to make a big difference. The indication for Watchman device, for instance, I think it's really unreasonable to offer this kind of device to anyone with atrial fibrillation with chest VAS score of 3 or more. The reason is, you really eliminate the source of thrombus and source of emboli without the need for taking anticoagulation. And really, this is priceless to a certain degree, because these medications are not safe, and these medications may have really kind of not very, kind of subtle side effects, from headache to cold extremities to not feeling well to GI discomfort. So if you can really eliminate the need for these medications lifelong, and can offer something that can be comparable, I don't think is really going to be a bad idea. So I tend to offer this device to a lot of patients with chest VAS score of 3 or higher. Now, certainly, if you have somebody who cannot take a blood thinners for financial reason, compliance issues, excessive bleeding, bruising, history of anemia, in that case, these medications should be really offered. And remember, this procedure is really safe and effective, takes about 12 to 14 minutes, and success rate is about 99.6%. So it's pretty high success rate. You have to have 45 days TE after the Watchman to make sure that there's really no leak around the device. But sometimes we really don't do it. Actually, most of the time we do it, but sometimes if there's need not to do it, and we feel that the initial implantation was successful, in certain patients who are elderly, doesn't want to have the TEE, in that case, it's not unreasonable to stop blood thinners like 1 month